Okay, I am Robin Strongin with Health Team, and I'm here today with Leah Binder. And Leah, you are president and CEO of LeapFrog Group, whose mission is all about improved patient safety and quality. And we're going to talk quite a bit about that. I know that you're a regular contributor to Forbes and Harvard Business Review, and you do a lot of writing. And we've been colleagues for quite a while now. So I know for a fact that you and I have seen the landscape in this area change over the decades. But one thing really has not changed, and that is, I mean, all of us in this area of work has to have the patient and patient safety be front and center. I mean, if we're not really about that, I'm not really sure what any of us are doing here. And so that is fundamental. So let's start actually with when you guys at LeapFrog think about patient safety, help us understand what that means exactly.
Well, first, thanks for having me, Robin. This is really a joy to be able to just sit down and talk with you and
Oh, thank
do it
you.
publicly. But either way, it's wonderful. And you've just been such a leader and just such a fresh voice always in healthcare.
Oh, that means a lot. Thank you.
You're a disruptor and in a
Yeah, I,
best
I hope
possible way.
so.
I love that. It's the best possible kind of disruptor. So
Thank
real
you.
inspiration for me.
Thank you.
So I'm, yeah. So patient safety, I've always thought that the term patient safety is not a great term.
Right.
We use it because people understand it, or at least people in healthcare understand it. Actually, the public, we've tested it before, and the public does not understand it.
Oh,
If you ask, oh,
interesting.
what do you think about patient safety? Are you concerned about patient safety? They will say, well, I do think that hospitals should have like sprinklers, and they should have fire alarms, and they don't see it as they don't see it as like accidents, errors, injuries, infections. They
Interesting.
don't see that. But if you ask them specifically about accidents, errors, injuries, infections, they get very animated. And
Mm.
invariably, I don't think I've ever talked to a person anywhere who doesn't have a story. Oh yeah, that happened to my aunt. She had an infection. She went to the hospital for just one day and blah, blah. They tell stories. Everybody's had an experience once they understand what patient safety is. But in healthcare, it's a term of art, certainly, and people in healthcare understand it. But I don't like the term because safe, it just sounds too boring.
Broad,
Like
maybe. Yeah.
broad. It also just sounds moderate or something. It just doesn't sound
The
like
urgency isn't really there.
right. It's like patient safety. It's like it
It's a
doesn't
it's
sound like
a
people
giveaway.
dying of sponges left in after surgery. Like that. We're talking about things that are really pretty
Harmful.
dramatic and horrible in some cases, or just really urgent issues that are in some cases, not always, but some cases catastrophic to people's lives. And we don't talk about it that way. So, we try at LeapFrog to make sure that our language tries to get at the heart of this issue, which is
Mhm.
this is about respect and dignity and human lives and just treating people the way we all want to be treated and addressing a problem that is truly a tragedy in our country that we can do better with. So that's patient safety is about errors and accidents and injuries. They are very prevalent. And there was just a study that was done by the Office of the Inspector General, which is,
In Health and Human Services.
yes,
Okay.
in HHS. And they pulled hundreds of Medicare records, patient records, and they had physicians in some very carefully thought through process go through
Okay.
these records to find errors, accidents, injuries, infections. And they found lots of them and concluded at the end that 1 in 4 patients admitted to a hospital on average will suffer some form of adverse event. One in
Oh my
four.
God.
And they said about half the time, I think like 40% of the time, those are preventable.
That's
The
what
other,
I was going to ask.
yeah.
Yeah.
Now, the word, how you define preventable is
Tricky.
that changes over time. Yeah.
Yep.
But that said, 40% preventable is still even, let's say 1 in 8 suffer a preventable adverse event. One in eight is that's an
It's
astronomical
huge.
rate of harm. It's horrible.
It's unacceptable. What are the statistics? Like, how does that compare to, say, 10 years ago? Have they been because To Err is Human was a big report that came out many years ago. Let me ask it this way, have we moved the needle so that I know for a fact, based on the work that you and your colleagues are doing and others are doing in this area of harm reduction and systems improvements, that efforts have been made over the years, but something is holding us back from getting to goal. So, can we take a step back and what are some of the reasons that this is still happening?
So let me back up from that just to
Yeah,
say
yeah.
that I'm going to say that I'm like the world's biggest optimist. So I
Okay. I
believe,
love that.
yeah, we are going to solve this problem, and we are well on our way.
Fabulous.
Well on our way. Now, there are some pretty troubling statistics, and I have lots of colleagues who will say, "Oh, please look at the statistics." The one I just named is a good
Is
example.
up at the top.
Yeah, I mean, one in eight, just to this. I
Is
mean,
not okay. No.
like look at a automate like some of the founders of LeapFrog are we were founded by employers. So some of them were automakers. GM was very actively involved in the early days and still is involved. So GM would say 1 in 1 million defects in their cars. 1 in 1 million defect rate is high. Okay, so we have a 1 in 8 or 1 in 4 defect rate basically in healthcare. That's like,
Yeah.
and it's more important. I mean, I like my car, but
Yeah.
I like my life
More.
better.
Yeah.
So anyway,
And
I think,
replace your car.
yeah,
Yeah.
exactly. So I think there's a long way to go. So I don't want to say that I'm just, sugarcoating everything. However, when we look at data and LeapFrog, we look at data all day, and we look at data and we look at some of the studies that have been done. And one that came out in particular from JAMA looked at millions of patient records over the past 10 years. Well,
Okay.
from 2009 to 2019. So it was prior to COVID, but really that that second decade of the 2000s. And
Okay.
they looked at millions, literally millions of patient records assembled by ARC. And they asked the question, how are we doing on adverse events associated with different treatments? And the way that they presented the paper was like, this is how we're doing on these treatments or something like that. Like they made it sound like the paper was about the treatments and the surgeries, but actually what it was about was the adverse events associated with people who have those conditions,
I
cardiac,
see.
things like that. And the adverse events they were looking at were the ones that have been publicly reported by CMS and LeapFrog, but in particular CMS. But we take them and report them in a different way that's gotten a lot of attention, which is our hospital safety grade. But anyway, so this study looked at a very good cross, like just everything on how we're doing on these adverse events. And it was stunning to me. The
Mm-hmm.
answer is we are seeing serious reductions in the incidents, serious 20-30% reductions in some, 40% in some.
Oh,
These
wow.
are infections, these are adverse events, these are errors, these are things that surgical site infections, complications from surgery, failure to rescue, things that are very important to all of us as patients. Things we fear the most when we go into a hospital for something. We're seeing reductions. Again, we're not where we want to be now, but that's progress. It says that something's been happening in the past decade that is working. And so the reason I like to point to that past decade as well is that I think we have had a new strategy in patient safety that we've introduced in this decade. And I say not just us at LeapFrog, but everybody collectively, politically, we've seen this introduction. It's bipartisan, but it's political, which is transparency in healthcare. We didn't used
Okay.
to have that. We didn't have transparency. In the 2000s, when LeapFrog was formed, there was no transparency. Nobody knew anything really about
Isn't
how
that
hospitals were doing.
insane? I mean, it's kind
It,
of
it is insane.
mind blowing a little bit there.
It is. I started at LeapFrog in 2009 at 8. I started in 2008. In 2009, one of the first things I did was testify before Congress, and they were doing a hearing on healthcare associated infections. And my argument at what my statement was all about, we should have transparency. We should publicly report these. And that was like, oh yeah, right, someday.
Yeah, good luck, lady.
Yeah, right. And we're doing it. And that really did come out of the Affordable Care Act. That
Okay.
publicly reporting, and we are doing it. We have, by we, I mean the United States of America, CMS is requiring public reporting of infection rates for the most common and most deadly in some cases of hospital-acquired infections. So central line infections, CAUTI, which is not deadly but very terrible, which is UTI infection.
Sure, with
Infection.
catheters and all of that. And I guess the connecting the dots is once you report, you can act on because you know where the trouble spots are, right? I mean, in theory, that's the
Right,
goal.
so
You
as
can fix it.
if you're a hospital leader, and that's what I've seen. When you're a hospital leader, you can see it, not only how you're doing, but how you compare.
So there's some
That's
competition going on there. And
Yes, it's a critically important to have competition, or also just benchmarking. Because how do you know? And this is true for board members, right? If you're on a board of a hospital, often board members are not in healthcare themselves. They might be, local
sure.
business leaders and things. They're sitting there, and somebody will say, "Well, we had a rate of central line infections. This was the rate. We had 4 of them, and in our unit of 300 beds or something, and now we got it down to 2, so we cut it by 50% and blah blah blah." And everybody would go like, "Yay, that looks great! Look at that beautiful curve going down by
Yeah,
50%, and everything's great." But until we had benchmarking that said
you
maybe
couldn't do that.
not a good rate, you're
Yeah,
to other hospitals like yours in the country, you're way up there. I'm not saying, by the way, that that number I just gave is just made up,
sure.
but the benchmarking issue is critical. And actually that is what we found was so useful about the safety grade when we launched it, is a lot of board members of hospitals would sit and say to their CEOs, "You said we were doing really great on, adverse events or
I
medication.
have this data to show you.
Yeah, why are we getting a C?"
Yeah,
You
yeah,
know, it's just what's going on?
doesn't add up.
It doesn't. And it forces the question in a productive way for boards, for CEOs, for C-suites, but also for everyone who works at the hospital. Everybody understands it. So we got to do better than this. And or we look how great we did, by the way. That's the other message that we think is so important is look at this. We got an A. That means we're really succeeding in keeping our patients safer. Doesn't mean we
So
couldn't.
I have two questions related to what you've been saying. Number one is, I can't imagine having this conversation without attorneys being somewhere in the mix, whether it's risk mitigation in the hospitals, and that injects a whole nother round of uh, stuff that needs to be dealt with. And what was my second question was, and I'll let you answer them both, but um, who has access? I'm going to have you, let's start with the second question, which is you talked about hospital grades. So how does that work and who has access to that? You've mentioned employers, the general public, and I know there's a lot of resource material on your website, which why don't you shout out your website now before I forget to ask, which I will ask again at the end.
Okay.
But yeah,
We have 2 websites.
okay,
One is it is the one that's best known, probably, hospitalsafetygrade.org. So
okay.
that's where you can search hospitals anywhere you want in the country, the US, your neighborhood or your grandmother's neighborhood, wherever you want to
So
look.
anybody can look that up, hospitalsafetygrade.org.
Right. And you can look at a bunch of hospitals, you can look at a map and see where, how a community's doing. But you can also drill down on one hospital. Our mantra is transparency. So we live that mantra. So it's very transparent how we do our ratings,
Hmm.
how we get to that grade. So you can dig in and we try to display that. We've made a lot of effort to display it in a way that lay people can understand. So, you don't
And
have to be out
related to
there. And
that, Leah, if you don't see a hospital, that probably means they opted out of participating in your survey or your work that you're doing. And to me, that would be a red flag in and of itself. Like, why wouldn't you want to share your data in this age of change? Shouldn't you be proud of where you are? Am I reading that correctly?
Almost, very
Okay.
close. So the hospital safety grade, we give grades to all general hospitals for which there's adequate data already available. And there often is, because what we were talking about earlier, CMS requires now hospitals
Okay.
report a good number of measures of their safety. So if a hospital, so we use that data primarily. We also use data from what's called the LeapFrog Hospital Survey, which is our annual survey that is voluntary. And
Okay.
it's the very best data we can possibly get on safety, but also on some outcome measures like maternity care, which we can talk about too.
Yeah, yeah,
Get
definitely.
data that that's unavailable anywhere else that employers and consumers really want. So we say, okay, let's get it. Let's, but for that, that's voluntary. And so there are hospitals that decline to provide us that data. And I'm sure they don't like that it's publicly reported by hospitals. So they don't decline. Although I will say now we have about 80% of hospital beds
Oh,
represented.
wow.
It's really great. I mean, the hospital
Wow.
industry
Congratulate.
has
That is
really
huge.
stable. Yeah, but I congratulate the hospital industry. I mean,
Yeah,
that
for sure. For
leadership, they
sure.
didn't have to do it. And they've come to the table. I think they're really committed to true transparency and recognizing that galvanizes change. But that's the area, to your point, Robin, where you should look at it and say, well, why did they decline? And you, as a consumer or a business leader, have really some influence if you just simply you can write a letter to the CEO or write a note to the CEO or put something out on X or just say, why are they declining? I'd like them to participate because I'd like to get that data. It always helps. So
It
anyway,
sure does.
that's
I love that.
so what we do is we take some data from the survey because it's better data than so let me give you an example.
Yeah.
The Leapfrog Hospital survey has some measures around medication errors.
Hmm.
That is the number one most common error made in a hospital by far. That is by far, and you can imagine it's complicated. You can have drug interactions, you can have dose misreadings. There's so many problems.
So many ways for that to happen. Absolutely.
Or you can give the wrong med to the right, the wrong patient the med, and there's all kinds of stuff
It's
that happens all
complicated.
the
Yeah.
time. And so, and it can be, very harmful, of course, to the patients. So, but there's no measure of it. CMS doesn't have any kind of measures around medication errors.
Wait, what?
They don't have anything. Oh, and the other big problem is medication. I'm sure everyone knows about this one. When you're discharged from the hospital and they give you this bunch of meds and you don't even know what they are half the time, and do they all fit together? Are these meds going to interact with each other? Because you might have been on different meds when you came in, and now you have a whole new set, and you don't, there's a lot of confusion around what happens when you're discharged, and there's a lot of problems with it. It's a major issue.
On that topic, can I just ask, as hospital, there are different types of hospitals other than general hospitals.
Right,
Do
right.
any of your surveys survey psychiatric
No, I
hospitals
wish we
out of
did.
curiosity? Hmm?
I wish we could. We don't have good
Not
measures.
yet. Okay, because I did an interview recently with Nora Super and Dr. Len Nichols about Nora's very public experience with depression and inpatient hospitalization. And Len's point for the public to understand is post-discharge, discharge from a psychiatric, there is no support with
Oh yeah,
discharge.
it's terrible.
None.
Mhm.
And just none. And to the point you're making, it's just there's so much work that needs to be done in that particular area. Okay, good to
I,
know.
I
Okay.
could not agree more on that. And certainly have had that experience in my own family. And
Yep.
I can tell you it is nightmarish and I would love to do it. But right now, that would be, it would, it
And
just,
again, a lot of that is our legal system. It isn't all the medical per se. Some of it's a complex, there's lots of strands that go into it. And we can probably do a separate conversation. Maybe we'll do one with Len and Nora, but not to derail. I just wasn't sure if you guys had that yet. because my money is on you will have it one day, Leah, if you
Yeah,
keep
well, we're
going the way
working
you're
on,
going.
it is something we visit every year to figure it out, but right now,
That one's a tough one.
that's
Yeah,
a, well, there's just, we have to rely on science of measurement because
of course.
we don't make up measures ourselves. We
Sure.
want to look, we just can't. So
Right.
anyway, so yes, more to come on that. And I welcome anybody who wants to come forward and say, here's, $5 million, do outpatient,
Do
do
work in this
mental
space.
health. We'd love it. We would, but we just don't have the resources right now. But
Hmm.
the other piece around medication errors is that problem of discharge, just handoffs in general with medications. It's extremely common. People will come home with, two different blood thinners. That's extremely dangerous. But they had the old blood thinner from their other doc, and now they get a new one, and no one noticed at their discharge that they had the two. That happens all the time. And so we actually have a measure. Okay, so the LeapFrog survey has a measure around those handoffs at discharge to help people. It's called medication reconciliation, and how do you do it? And there's best practices, and there's a measure on how to do it.
Sure.
And so we have that. We also have a test for hospitals to take to see if their CPOE system, which is the computerized prescriber order entry system. This is the system that can be used and is used most of the time when any provider issues a medication order. It actually checks against the medical record. So is
Sure.
the patient allergic to that, or is it, all the things? Is that the right dose for that patient? Wait, why are you giving a child that dose? Things like that. So the question that we ask in this test, the way that what we're testing for, is does that system work to the benefit of the patient? Is it alerting to these common errors, some of which we test for things that are kind of extreme, that would really harm the patient, or in some cases would actually kill the patient. So does your system alert to that? And we also test for frivolous alerts.
Mm.
Does it alert to something it shouldn't alert? Because when there's too many alerts,
Fatigue.
they ignore it. Yeah.
Yeah.
And that's dangerous too. So we test
Yep.
for, developed by David Bates and David
Oh,
Klassen
yes, yes, yes.
in his field. So it's a robust test. It's the only one of its kind. I wish there were more. I love to brag that it's the only one of its kind, but it's actually not great that that's the case. It should be everywhere.
Yeah.
Hospitals do not, very, very rarely does hospital get 100% on this test. Most of the time it's more like, 70 or 80% for the good ones, and some don't even, it's not good that they're not all tested. So it's very important for hospitals to test, and they do better the next time they take the test, which is
Oh,
good. They're
okay.
clearly paying attention to it. Anyway, all right. So that's a long explanation of what we look at. It's part of our voluntary survey. I think it's a resource for hospitals because they're learning
Absolutely.
something they can't find out any other way. And then the hospitals that once they do the survey, will use that data in the safety grade. So
I
some
see.
data in the safety grade comes from the survey. So hospitals do have an opportunity to sort of earn more points. It gives them a little bit of a head start on getting an A if they're able to do well on a few of the measures in the survey that we use in the grade. That said, lots of hospitals get an A anyway, and through in the hospital safety grade with CMS data only. But that's how we do it. And then you get into the website, you drill down into that grade for any particular hospital, and it will show you how that hospital did on all of the 32 measures that we use. Were they worse than average, better, or about average? And I think it's laid out in such a way that hopefully people can grasp it. They can also drill down on where we got the data. They can get very
Hmm.
knowledge about the numbers and all that stuff. We give them everything. And we also have the methodology on there and how we calculated the data, et cetera, how we weighted it. Um, so, I mean, I think that way you can go on and say, well, I don't think this hospital deserved an A. I think they should have gotten a B, or I think they should have gotten a C. It's up to you. I mean, you're the one who has to make the decision about these hospitals as an informed consumer. But we want to give you the
The
information.
tools to be
Yeah,
able to
and
figure it out
and
what works for you. Yeah,
exactly. And that's what we need. And I think that's been an effective. I think it's been most effective. I think there's a lot of consumers who use it,
I
but
went on and was playing
they
around, and it is very intuitive. It was not frightening. It was very nicely laid out. The navigation made sense. I found it extremely useful. I found some hospitals not on there. That kind of surprised me a little bit, but we'll go back to that. But I also, in one area, only because I'm now, a lot of my friends are becoming grandparents, and
Yeah.
I am too. And I know you've been doing a lot of work on maternal related measures of safety and quality. And I'd like to learn a little bit more about what you guys are doing in that field area, because I know the numbers are not good, compared to other countries. And it is really, really shocking when you hear some of the statistics and stories that families are going through. It's really you really can't believe that in 2025, given everything we know, like
Yeah.
what in the world is going on here?
No, I mean, depending on the statistics you look at, we're certainly not getting better
They're
than we were
brutal.
when our mothers were giving birth, and
Yeah.
we should be doing a lot better. And hopefully our daughters will, have a better experience than we did. But there's no evidence of that right now. So
God.
it's very dangerous, unfortunately. Um, we look at we look at a suite of maternity care measures that, again, are not available publicly by hospital anywhere else. It's a voluntary survey. That's the way we get it, by the way, is the employers are the ones that have stepped up to
Oh,
make this
that's
happen.
interesting. On
They,
behalf of their employees. Yeah.
no, on behalf of themselves, actually.
Oh, I thought.
Paid for this scare. They actually, this is a big
Oh,
line
okay.
item on their balance sheet is benefits costs. Someone was just telling me that it's like the second highest expense on their in their company. I mean, it's going up way too high, but it's nonetheless they're investing heavily in.
Now I have a million questions, but I'm going to control
Okay,
myself and let you keep talking.
they are, and the HR leadership is what founded LeapFrog, and it's what keeps us going. I mean, they're the ones that asked the hospitals on their behalf, would you please participate in LeapFrog so we get this data? They don't want them to give it to them directly because they don't know how to deal with this data. I mean, that's not what they do all day. They make cars and automobiles and airplanes. That's what they do. They
Right.
don't want to. They want LeapFrog to do that, and then give them back the data that they can
So
trust.
they can make decisions about yeah, okay.
So, and it helps, and then of course they make it available to their employees as well as the public at large. So it's, it works for everyone. But basically, we ask, wait, I forgot what I was saying actually. What were we talking about with the
What you're finding and what kind of research you're doing in the
oh, sorry.
maternity space. Yeah. What
Right.
specific areas you've been looking at?
Right, sorry. So maternity care is very important to employers in particular because they pay for half the births in this country. Medicaid pays for the other half. So it's very important to
Wow.
public purchasers as well. But most of the data that we have on safety and quality of care that's publicly available comes from CMS, which is the agency that runs Medicare. Medicaid is run mostly by states and they
Right.
supplement it. So CMS actually doesn't have as much of a stake in, or theoretically doesn't have as much of a stake in maternity care because Medicare recipients are,
Are not having babies anymore.
not having babies. Maybe someday 60, 70-year-olds will, but maybe I don't know why
Well,
they
that is a whole different topic for another day, and I'm one I'm
either.
not quite ready for. Thank you.
Neither. But
Um,
anyway, they don't.
Yeah,
So
that's not what
they don't
they're
have good data.
collecting so much. Yeah.
Yeah, I
But
mean,
it's the states with Medicaid programs are probably collecting
yeah, but they're
some
not all
extent,
publicly
not a
reporting.
lot.
No,
Interesting.
actually, let me give you an example. C-sections. To me, C-sections is the thing that most women want to know.
Right.
They just want to know what's the C-section rate, and they want to know a adjusted rate. They don't want to hear, well, that's because this hospital sees, high risk
Yeah.
populations, and that's what you usually hear. So there is a measure of that. It's called the NTSV C-section rate. It's NTSV basically means it stands for something I'm not even going to go into. Like it's clinical
Okay.
term, but it basically means the baby's in the right position. First
Okay.
mother, So low risk pregnancy, basically. And so if you look at just low risk pregnancies for every hospital, you're comparing them apples to apples to an
Right, sure.
academic medical center to a rural hospital, for instance. So that data is not publicly available. And I remember, over 20 years ago, when I was first pregnant, wanting to know that myself. And I was shocked that I couldn't find it. I said, "You're kidding. Everybody wants to know that." Couldn't find it. And it's still the case. The hospital
Wow.
still can't, except for LeapFrog. So we do publicly report C-section rates by hospital now for 80% of the hospital beds. So that's a big one. If you see decline to report on that, get on the phone and call them and say, "I want this
Okay.
data." And anyway, so that's an example of what we report in our maternity care. And it's a very important measure. We're not seeing as much progress as we'd like to on that. In fact, we're not seeing any real progress on C-section rates nationally. So, and they're too high, and they're higher than other countries.
And
C
this, to be clear, are C-sections for people who really don't need them. It's not an emergency. It's not that there was some particular issue that you know in advance necessitates scheduling because you're high risk or there's some real need other than maybe convenience or something else going on.
Well, yeah, the measure is designed to identify low risk
There
pregnancies
you go. Okay.
generally. That doesn't mean though that
Something doesn't happen in the moment and they need to, yeah.
there's definitely a need for C-sections. So
Yeah,
I don't mean, and we don't, our measure says that 23, it's based on World Health Organization, that 23% or something of those low risk women should be, it's okay for getting C.
sure.
I'd like to see it lower, and I think we'll work on that because some states have brought it down to as low as like 18 or 15%. But we accept that there's certainly a need for C-sections in some cases,
Yeah, of
but
course.
not as many
But
cases.
not at the rate that you were seeing.
No.
Okay.
And remember, these are low risk women
Right,
and
that right.
young women who are getting major abdominal surgery.
Surgery.
Like this is a very significant surgery, like way up there on the list of dangerous surgeries. And they're getting this major abdominal surgery, which impacts their next birth as well, by the way.
Sure.
It's cumulative effect. So that's how we need to start thinking about it. And it's the most common procedure performed, surgical procedure performed in hospitals by far is a C-section for
Wow.
any procedure, even though it's only this group of, people that get it. So anyway, we look at that. We also look at episiotomy, which is
Hmm.
it's an intervention that used to be done almost routinely in some hospitals to basically open the birth canal by cutting it. And it's uh, now ACOG says to avoid doing that. It is not a safe procedure. It shouldn't be done.
Oh,
It's not the standard
wow.
of care anymore. It used to be more routine. Now it's not the standard of care. And finally, we are seeing significant reduction. We've been publicly reporting rates.
Oh, that I did
uh,
not hear that. Oh my
Yeah,
God. Okay.
for some reason, we're the only ones paying attention to episiotomy, which I think is a really important issue. Obviously, for women, it's huge.
Yeah, I
So,
would say so. Yeah.
so that's anyway, so that's gone way down. We're really, really pleased to see those numbers,
Oh,
but
that's
that's
fantastic.
yeah.
Wow.
And
Okay.
that's benchmark public reporting transparency helped. All we did was galvanize it, but I think the hospital community and physicians have shown really significant leadership and they made a real difference and it's saved a lot of lives. So we give them the credit, but they needed the galvanizing force because otherwise it wasn't moving. And I think by the way, just to touch on that we look at is does the hospital allow doulas to assist
Yeah,
women in
we've been
labor?
talking about that, my daughter and I, about doulas, and yeah, so that's a big question still. And not all hospitals do allow the doula with, right? That's my
Right.
understanding.
No, they don't. And you can look it up on LeapFrog by hospital. So take a look.
Oh,
I
we will.
could allow them, but I think we'd like to see that movement expand. And, to the credit of employers, some of them have, not all, but, some of them are covering doulas for their
Interesting.
employees. And I mean, really believe in this. And there is some good literature that they can actually certainly make for a much better outcome and experience for women, but also a better experience postnatal for women.
Hmm.
So a lot of doulas basically go home with the woman,
Right.
and they work with them for a period of time, sometimes up to a year, as they accommodate having a new baby. And there are just so many ways that we could do so much better, and doulas are a really good example of where we could do better. There's some issues in expanding the workforce and having enough doulas and having kind of one standard of certification for who, for them, things like that, that they're still working on. But we are very much in favor of seeing that movement grow. And I think, and ultimately, it will improve outcomes and cost effectiveness, by the way. It's much
It's
better.
so important because I know there are workforce issues within the doula community itself, numbers, and as you said, licensure and training and all of this. But at the same time, there's also shortages in the more traditional roles of
Yep.
healthcare providers, particularly since COVID and even before. And
Mhm.
so we are nowhere near, whether it's with maternity care, whether it's with, on the aging side of the spectrum, on the younger side in the disability, and we just do not have enough help. And if there are ways to train people who can be there, I just think it's sort of a no-brainer, but
Mhm.
there are there are a lot of reasons why it's hard to start activating these kinds of solutions. But pretty soon, if we don't, we're going to see a cratering because we just have too many people with too many needs and not enough people who are trained to be helpful. In almost every conversation I've been having with Health Dame, there's some element of this.
Mhm.
But what you're doing is helping people, consumers who can go themselves or through their employers, of course, if that's something that's relevant to them, to be able to be better informed. Not everything is an emergency situation where you have to go to a hospital immediately. We have a lot of people with chronic conditions, and part of helping to plan what's going to be best for you and your family is having this kind of information available. And so this is just so helpful. So when I get this up on HealthStream, we'll also have all of the links to all of the resources and the website so people can more easily find some of what you've been talking about, because how
Definitely.
helpful is that? It's incredibly helpful. And if your hospital isn't part of it, then, you can make some noise and ask them to please, step up a little bit here, because it could be life and death, or at least make for a very unpleasant experience when it doesn't have to be. Who the heck wants an infection on top of everything else? Stuff like
Exactly.
that, that's pretty miserable. And the issue of medication error has been, boy, that one has been a tough one for a very, very, very long
Mhm.
time. And I remember when CPOE first came out, and that
Yes.
was something of a breakthrough, and it has helped for sure.
Oh,
But
definitely.
it's made a big difference. And you know, I remember when Senator Frist, who was a surgeon and a pilot, started with the quality checklists and made the comparisons. I think he wrote something in Health Affairs back in the day, right? Go
That's
ahead.
in, by the way, checklist is in the LeapFrog standard for
There you
everything.
go.
You use the checklist.
Yeah, so there are some really accessible tools, both for the hospitals and you guys are branching out beyond inpatient hospitals as well, right? So maybe as we wrap up, you just mentioned some of what you're doing outside the inpatient space.
So we're now rating outpatient surgery. So outpatient, sometimes it looks like a separate center, but it's actually affiliated with a hospital.
Sure.
Um, CMS does not actually provide as much data, not very little data actually, on the quality and outcomes for and safety of outpatient procedures. So we're asking about its safety. So we
Hmm.
have over 1,000 hospitals reporting on outpatient procedures and safety and complications, things like that. We have a separate survey now, but it's aligned with that outpatient survey, which is the Ambulatory Surgery Center
Sure.
survey. So ASCs are really a booming movement that's out there. There's a lot of them now, and they're growing. And I think they have enormous potential, and some of them are showing just incredible
In a good way. In a
in a
good
very
way.
good way. Yeah, I mean, they're settings where typically not, I guess I don't know the typical, but I will say the ones that I have seen that are excellent, uh, they are they're providing, a limited number of or a limited set of procedures.
Yep.
They're very, very, very good at it. When surgeons and teams, OR teams, are practiced in a particular procedure, when they do a good number of them, they're better. It's like any,
It was
it's
like
like,
when I had my cataracts done in a
yeah,
ASC. I
exactly.
mean, it was like everybody knew who was where. There were checks and triple checks and quadruple checks. And I mean, it was, I wouldn't say an assembly line per se, but it was not unlike that. And
Yeah,
but everybody knew it was a routine. It really functioned very, I was the wild card because of course I'm always a pain in the neck. Nobody wants me as a patient. I can promise you that.
me neither.
But it was really something. It was you weren't you got the feeling like everyone knew what was going on, what they were going to do, what if there was a problem. Beside me trying to get up in the middle and saying, okay, I've had enough, I want to go home, and they weren't quite finished. And I started sitting up and then throw me back down. But
Well, that's very
okay.
naughty.
I
That's
was very, yeah, well, I had had enough. I was like, oh, how hard can this be? I'll do it myself. But little eye surgery never hurt anyone. Um, just kidding. But in any event, yeah, well, that's very promising. And of course, the more you do something over and over and over, we know from other research that, you only get better with it and more experienced. And new technologies come along, so you have to make room for getting up to speed on that. You want the years of wisdom for the person who's been there a long time, and you want the new person who's really understands the technology. Somewhere in the middle is, really a great spot to be in. So,
and
um,
practice makes perfect. I mean, it's
exactly,
you can be a
exactly.
maestro musician. If you don't practice, you can't get in front of an audience. You're not ready, even if you're the best of the best. They
Yeah,
all
that's what they say. How do you get to Carnegie Hall? Practice, practice, practice. That's the old
exactly.
joke.
And you
Yeah.
have to keep doing it. My sister-in-law's she's a concert musician, and she practices
All day long.
all the
And it's
time.
not for
That's
1 hour either. It's
no hours and
yeah,
hours.
hours and hours and hours. I didn't realize how much physical therapy musicians have to undergo because, they're using over and over either whatever the instrument, that body part is taking a beating. But, when we're sitting in the audience listening, it's, a beautiful thing.
Yeah,
But it's hard work, what you don't see. And
very hard.
yes, very
And
true.
I will say on the inpatient side too, just and ASCs, we actually do look at volume for a number of
Ah, great.
so
It's
that
yeah,
we've sort of known for that. We've been doing it since the beginning, where because that's a big issue. And by the way,
predictor.
a
Yeah.
lot of hospitals that are not doing a sufficient volume to be safe for certain procedures. So it is really, yeah, I think it's an important part of the survey to look up. So if you've got, particularly if, like some cancer surgeries like pancreatic surgery, that is an extraordinarily difficult and complex surgery. You do not want to go to a hospital that only does one a year, or a doctor who only does one a year. Oh my God, do not.
No, run away. Yeah.
Oh, and there's a lot. So, watch out.
Something to look out for. Yeah. Is there one thing that's sort of new on the horizon that you guys are paying close attention to, or what would that be that because you look at trends too, so you really kind of are on that pulse. What are you looking at, you guys?
Well, there's a couple of things I would point to. One is we're looking at ER boarding, which is a problem that's been growing where um, you go to the ER, and this is not about wait times, by the way, that's another issue, but you wait and you see the physician and they admit you to the hospital. So you have something serious, they're going to admit you, but they don't have a bed, or they want to transfer you to another hospital and they can't get a bed. That happens all the time with psychiatric admissions. So They put you on a gurney and they put you in the hallway in the or somewhere in the ER. And let's say you've been admitted to that hospital. You are literally considered, let's say, a med-surg admission, and you're on a gurney in the ER. Your nurse is probably like on the med-surg floor. Maybe it's on the 10th floor. They're not there with you. They will theoretically come and check on you and figure out what's going on. But nobody in the ER is anymore your doctor or nurse. Now your doctor or nurse
Oh,
is
so
on,
you're like in a no man's land.
right? And for a long time. So this is happening for hours, but sometimes days, where people get stuck in this on a gurney. And you can imagine it is incredibly unsafe because,
In every way.
who's going to watch to make sure you're getting everything you need? It is terrible. And it's an increasing problem. Hospitals themselves are alarmed by it. They don't, they're not sure what to do. There are some solutions they could be doing, but it is hard. It is a hard problem. We
That's
get it. We're
horrifying.
monitoring it.
Leah, that's horrifying. It's not only a staffing shortage, it's a bed shortage. It's probably a lot of reasons why it's happening. It's never an easy.
Yeah, well, it's a bed shortage, but there's a great researcher named Eugene Litvak who you should interview for
Okay.
your
What's his last name? Eugene?
Litvak, Litvak, I think it's spelled.
Okay,
He
I'll look it up.
He's fascinating. He's come up with a whole method that hospitals can use for their scheduling of their ORs and their scheduling just in general of the services. And when they do that, it smooths out everything and it reduces costs at the same time, and it prevents
So there's a good solution that will
surgery.
make it better.
There
We
are
just have to
solutions.
get
There
it
are
to the
out there.
hospital. Oh my God.
Well, they have to, there's a whole bunch of
I
hospitals
bet.
to be a little
Yes.
more motivated, financially and otherwise to think through options. And there are some really built-in things that they can't do anything about. So I understand this is a very complicated problem. Nonetheless, it is terrible for patients. And so we're asking hospitals to report on how, the extent to which this is happening. And that's a big one. And we're going to monitor that. And that's a big priority for us because it's so dangerous and it's just not.
That's alarming. Okay.
So, and then the other, and by the way, that was brought to us by hospitals. So I will say that
Oh,
again,
they know this
credit of the
is, they
hospital
need to get
community.
their arms around this. Yeah.
Yeah, they know
And
this is a
patients
problem.
and families are probably screaming bloody murder too. Just,
Oh, yeah, it's
yeah.
terrible. Terrible. So then the other thing, the broader trend issue is AI and
Sure.
how we're going to integrate that into healthcare. But for us, for LeapFrog, our focus is how do we make sure and how do we encourage hospitals and others and ASCs and everybody to use AI to the benefit of the patient. And what we are seeing right now is that's not necessarily the first road that a hospital, for instance, will go down. They might use it to improve their billing practices or something, but they're not necessarily immediately implementing it in some of the cutting edge ways we think it can be implemented to the benefit of the patient. So, for instance, detecting when someone's at risk of a fall or at risk of some kind of adverse event. There are subtle signs that can show up in the medical record or show up in other kinds of monitored systems within a hospital. And AI is very good at synthesizing a huge amount of data
Sure.
quickly and then coming up with some analysis of that data. That's what's amazing about AI. It doesn't just say, well, here's the numbers. It says, it appears that this blah, blah, blah is happening. Like it actually analyzes it. So
So
you
it
could,
could be used for those medication errors where there's so
Mhm.
many different variables, but it can breeze through it so fast and flag or say this is, yeah, yeah.
That's a great example. And it could also look through a lot of sentinel events let's say a lot of infections have been reported, and it will look at all the details of all those infections and maybe say, well, the pathogen seems to be sourced from this room.
Oh,
Patients
interesting.
all seem to be going through this room before they get this infection. Those are things that
That's pretty
humans
cool.
cannot do. Yeah, there's lots of really cool applications. We're very excited about AI, but it's got to get used. And so I think healthcare tends to be slower at adopting technology, much slower than other industries.
I love the lawyers. My son is one, but they sometimes. But
No,
to
it's
be
not just the
fair,
lawyers, though. Oh my God.
yeah, to be fair, on the one hand, you have the cowboys and the tech people who want to get the stuff out without any guardrails, and then you have the legal people that are pulling them back. And somewhere in the middle, again, is where we need to find ourselves. So it's always that push-pull. And meanwhile, it's the patient who's being yo-yoed around and, not
Mhm.
benefiting from what they could be, but trying to protect them from, the other stuff, let's call it. But oh my gosh. So patient safety and quality. Thank goodness for LeapFrog. Leah, you're like, wow.
Uh,
It's just, when you're sick, you want to know you're doing everything possible, and you are, but then there are these systems issues that you're dependent upon. And yet you can make some noise, you can ask some questions, you can make informed decisions. Obviously, in an emergency situation, you have less ability to do that. But if you know ahead of time, what are the hospitals where, if God forbid, you needed a loved one or yourself needed to go, it's good to do some of that work when you're feeling, not stressed and sick and all of that. So you have a plan. You literally need a plan
exactly.
to keep yourself out of harm's way as
That's
much as
true.
you
No, it's true.
can,
And if you can, if you get a loved one or a friend that can stay with you as long as possible,
even
while
better.
possible, that's also very important. And they should be a little bit pushy, they should ask, what is that medication you're giving? Just want to
My
tell
Brooklyn thing, usually I do get very New York when I'm advocating for someone
you. Yeah,
because
you gotta
I
be.
mean it can be life and death. And you can still respect how harried and busy and overworked a lot of the staff is. But if there's a situation that is just unacceptable, then you better be jumping up and down and helping to get the right people there, because I'm
Mhm.
here to tell you really bad things can happen if you don't, and if you're not really vigilant, and that's just not okay. So yeah,
Right.
one
Just have
needs
to
to be
be.
very Brooklyn when it comes
Yeah,
to
you
healthcare.
have to be Brooklyn.
See,
Yes, you
yeah, you
do.
really do have to be Brooklyn is what I would say.
But I have to give it to one thing when you say that too. I just think of nurses as that they're really heroes of healthcare. I'm telling you, when anyone who goes to a hospital will see that right away. This is most of what a hospital does is deliver nursing care. And so when there's not enough nurses or they're stressed for whatever reason, or doing workarounds and things are just not functioning right, they're the first to know. And they are the ones that you do need to have a relationship with that hopefully is good, but you've got to be able to say, what is that? Let's just check that medication. I just want to make sure it's on the
Oh,
medication.
they really are the backbone of
Mhm.
the whole operation there. And I've been very lucky to, in fact, I'm going to be interviewing several nurses in the near future because
Okay.
it's so critical. And I know we're pretty much at time, but I have to ask my last question, Leah, which is, what song can we add to the Health Team playlist with your name on it? What you got
His,
for me?
history has its eyes on you
Oh, tell me
from
more. I
it's
don't.
from Hamilton,
Of course.
and it's George
Perfect.
Washington sings it to Hamilton, and
Wow.
I think it gets sung back. I think it's another scene as well. It's sung back, but it is very moving to see that sung on the stage because it's George Washington singing "History Has Its Eyes on You" to us in the audience. And
Yeah.
there's something really mystical, like that's true. We're the, we're the eyes that are
Yep.
looking, the next generation that is looking at what
Such a
the fire
perfect
generation
song
do.
for today's time, for the work that you're
Yeah.
doing. And what a great selection. I think you're my first Broadway selection of music. So congratulations. Oh
Oh,
my
well,
God.
good.
That's
Well,
fantastic. And thank you so much for taking the time, Lee. I really appreciate it and all that you've shared with us today. And I will circle back soon. But again, sincere thanks. This is really important work that you're doing, and I'm glad we'll be able to share it with as many people as possible. So thank
thank
you.
you for your work too, and
Oh, that's
we'll
very
stay.
nice. Thank you. Have a great day. I'll see you soon. All right.
Okay,
Bye now.
bye.